female reproductive system. Our focus remains on the histology, but we'll discuss some embryology component also and side by side some physiology as well. Embryologically, when we talk about the reproductive system, maybe male, female, majorly it is coming from intermediate mesoderm. Intermediate mesoderm is giving us the genitourinary ridges, and the genital ridges will give us the gonads. Because we are talking about the female, so gonad will be the ovary. Ovary is developed from genital ridge, intermediate mesoderm. It is also giving us some genitourinary ducts, the intermediate mesoderm, and we understand it is the Mullerian duct, which is also called as the para-mesonephric duct because it is on the side of the mesonephric duct. So para-mesonephric duct or Mullerian duct is the female duct, and it will be giving us some derivatives like it is giving us the uterus, the uterine tube, and also the upper 1/3 of vagina. So in histology, we will be first focusing upon the ovaries, and after that we can talk about the uterine tubes, and then we can also focus upon the uterus, the cervix, and also the vagina. Let us first focus upon the magnified picture of the ovary. Ovary is covered by peritoneum, and that is producing one epithelium. That epithelium is simple cuboidal epithelium called as germinal epithelium. It is a misnomer. Why it is a misnomer? Because that is not the one which will form the oocyte. Oocytes basically, which are mostly primary oocyte here, what you have is primary oocyte. Just before ovulation it will become secondary oocyte. So primary oocyte changes into secondary oocyte, and it is secondary oocyte which will undergo ovulation. So all the time it was primary oocyte, primary oocyte, primary oocyte. That is coming from the primordial germ cells. So remember, it is the epiblast which will be forming the primordial germ cells, and primordial germ cells, they migrate to the gonads and they form the oocyte. It is the same story in males also. Males epiblast will give primordial germ cell, but it will come to the testis and form the sperm. So maybe it is sperm or maybe oocyte, they all come from primordial germ cell which come from epiblast. My point is, this epithelium which is on the surface of the ovary, which is called germinal epithelium, is a misnomer, wrong name. It does not give the oocyte. Oocyte came from primordial germ cells. So let us magnify the diagram of ovary. As I have mentioned, the epithelium on the outer surface will be simple cuboidal epithelium, and that simple cuboidal everything which I talk about is one MCQ, continuously repeated. So wrongly called as germinal epithelium, but it is not germinal epithelium. Now deep to that will be tunica albuginea. So there is some connective tissue deep to that, and that is tunica albuginea. And then if you look at the ovary, ovary has outer cortex and deeper inner medulla. If you look at the medulla, you will find this is the medulla where you will have connective tissue plus neurovascular bundle. So once again we can repeat, ovary will have outer cortex, inner medulla. The outer cortex which you see is here, this is all cortex only, where you will have ovarian follicles. Medulla is deeper, inner medulla with connective tissue and neurovascular bundle, which is seen here. We can draw ourselves also. This will be the medullary region, the deeper region with neurovascular bundle, lymphatics and nerves, artery, veins. But our focus remains on the cortex. In the cortex, peripheral cortex, you will have what is called as primordial follicles. Follicles you can remember in a sequence. First there will be primordial follicles which are in the superficial cortex, outermost. Then we will have primary follicle, then we will have secondary follicle, and then we will have the tertiary follicle. Tertiary follicle, which is also called as Graafian follicle, and it is the Graafian follicle which will be giving us the secondary oocyte. All these oocytes which we see, they are primary oocytes, except for the one which is undergoing ovulation. Primary oocyte changes into secondary oocyte just before ovulation. So the cell which undergoes ovulation is secondary oocyte. The primary oocyte which you are talking about before birth only, we have mnemonic PP1P that tells that this primary oocyte is arrested in prophase 1, that also in diplotin stage, until puberty. Only after puberty it can change into the next stages. So all these primary oocytes which you see here, all are primary oocytes only, except for this one which is secondary. So these primary oocytes, they are all PP1P. What is PP1P? Primary oocyte arrested in prophase 1 diplotin stage until puberty. Only at puberty you will start having LH hormone surge and primary oocyte can become secondary oocyte. The primary oocyte becomes secondary oocyte just before ovulation, and this secondary oocyte which you get is entering meiosis 2, arrested in metaphase 2 until fertilization. All of these are MCQs again. So this secondary oocyte, you remember M2F, it is arrested in metaphase 2 of meiosis 2 until fertilization. If fertilization happens, then only it can proceed further into anaphase, telophase. So the first mnemonic is PP1P, which is for primary oocyte arrested in prophase 1 until puberty. And the next mnemonic M2F is secondary oocyte arrested in metaphase 2 of meiosis 2 until F, that fertilization. Now here you see primordial follicles, they will be covered by simple squamous epithelium. So when we are looking at the primordial follicle, this is the primary oocyte, they will be covered by what is called as the simple squamous epithelium, simple squamous. Now as you talk about primary follicle will have two stages. The primary oocyte which we are having is now covered by cells which have become cuboidal. So they become cuboidal and it can be single layer, later they become multiple layered. These are called as granulosa cells, and granulosa cells are important as they are covering the primary oocyte. They give hormones like estrogen, they give hormones like inhibin. Inhibin is the hormone which you will find is for feedback inhibition, because we understand that the follicles, they are under, say there is an hypothalamus giving gonadotropin releasing hormones to the anterior pituitary. Anterior pituitary is giving us hormones like FSH, LH, and under FSH you have follicles, they are working. Now follicles, the granulosa cells, they have a feedback inhibition and they can always go back and tell the anterior pituitary to reduce the FSH, because multiple follicles start developing. You don't want all the follicles to mature, only one follicle should mature. So inhibin is required. This is called feedback inhibition. It is done by inhibin and that inhibin is given by granulosa cells, these granulosa cells. So I'll repeat. You have hypothalamus which is having gonadotropin releasing hormone which will work on the anterior pituitary. Anterior pituitary will then give us FSH, follicle stimulating hormone, and luteinizing hormone. Here we are focusing upon FSH. The follicle stimulating hormone will stimulate the follicle. There will be granulosa cells on which it is working. Granulosa cells help in maturing the proliferation of follicles, but then you cannot have multiple follicles developing. You should have only one follicle developing per month which can undergo ovulation. So how do you make sure the other follicles are compromised or they are not developing? Because you are having multiple follicles, how do you make sure that only one is developing? So how do you remove the others? Inhibin. The granulosa cells which you are showing here, the cuboidal cells around the primary follicle, will be giving us inhibin also, and that inhibin given will go to anterior pituitary and will inhibit the secretion of FSH, so that only little bit of FSH is there which is enough to mature only one follicle, and that follicle you can see here will then become secondary and tertiary follicle. You see, secondary follicles start developing antral spaces, and secondary follicle will be having a zona pellucida also. So there is a zona pellucida glycoprotein membrane which attracts the sperm for fertilization, not only secreted by oocyte but also granulosa cells. So when you are talking about the secondary follicle, what is the specialty? Secondary follicle, you will have the primary oocyte now covered by what is called as the zona pellucida, and zona pellucida is a glycoprotein membrane, and that zona pellucida is to attract the sperm for fertilization. This zona pellucida, which is glycoprotein, is given by not only the primary oocyte but also granulosa cells which are surrounding it. So you can show the granulosa cells which were surrounding here, the cuboidal cells, and these granulosa cells, not only they were giving us these cuboidal cells, granulosa cells in the secondary follicle which has the zona pellucida. So zona pellucida given by granulosa cell plus the oocyte, again MCU. The granulosa cells also give us what is called as the estrogen. Now how do you produce this estrogen? Actually, around the secondary follicle you will have some theca cells. The stroma cells, they condense, form theca cells, and those theca cells, they are under LH hormone. So LH hormone work on the theca cells. You can show them, there will be some theca cells also, and these theca cells, will draw our own diagram as well. These theca cells under LH will give us the androgen kind of hormones like testosterone, but these androgens are then given to granulosa cells, and granulosa cells can convert them into estrogen. So as I mentioned, granulosa cells, they are giving estrogen. How they are giving estrogen? Because theca cells which are still on the outside gave them androgen, there will be aromatization and that will change into estrogen, and they also give inhibin. So granulosa cells, they are giving zona pellucida, estrogen, inhibin, all that you remember. Then you have this tertiary follicle. Tertiary follicle will have a very large antral space. You will notice that in the tertiary follicle there are some granulosa cells surrounding the primary oocyte, multi-layered. That will be called as the corona radiata. We will draw our own diagram. There will be some granulosa cells which are holding the oocyte to the peripheral granulosa cells. These are peripheral granulosa cells, and the granulosa cells which are holding the primary oocyte and corona radiata here. This bunch of cell is called cumulus euphorus. Cumulus euphorus, will again draw a diagram. Now when there is ovulation happening, a secondary oocyte is ovulated. It is surrounded by corona radiata cells, the granulosa cells, and those granulosa cells, they will be important later as the secondary oocyte will go and try to get fertilized. Mostly it is not fertilized because sperms are not available, but if it is fertilized, then the Graafian follicle will change into what is called as the luteal stage, and in the luteal stage it will be having the granulosa cells, granulosa lutein cells, giving us progesterone. Remember PP, progesterone is the hormone of pregnancy, and it is given by granulosa lutein cells because this is corpus luteum basically. So they will be called granulosa lutein cells, and they will also give little bit of estrogen. So corpus luteum give mostly progesterone, little bit of estrogen also, and estrogen is formed by aromatization of the androgens which are given by still peripheral theca lutein cells. So in the center, say for example, you have granulosa lutein cells forming progesterone and little bit of estrogen, but around that you have theca lutein cells which are giving the androgens because those androgens are required to convert into estrogen. Now if the oocyte was fertilized, then you will have corpus luteum of pregnancy and progesterone remain high, pregnancy, supporting pregnancy, but most of the time there is no fertilization. So the corpus luteum changes into corpus albicans by 25th to 28th day of the cycle, and it will be degenerated and level of progesterone will come down. So corpus albicans is shown here. Let us draw this diagram ourselves now. So as you understand that this is the ovary, you'll have a outer cortex, inner medulla. This is the medulla. In the medulla, you'll have the connective tissue plus neurovascular bundle. That is the medulla, outer cortex. In the cortex, you'll have primordial follicles, but these primordial follicles are in the peripheral cortex. And as we have mentioned earlier, there will be this simple cuboidal epithelium. That simple cuboidal epithelium, which is wrongly called as germinal epithelium, is also to be mentioned. It is basically the peritoneal covering, which is, you can say, peritoneal serosa covering the ovary. Deep to that was tunica albuginea, and deep to that you will have the primordial follicles. Primordial follicles, as you draw, they will be having a primary oocyte. Around the primary oocyte, we will have this simple squamous epithelium, and this simple squamous epithelium is on the primordial follicle. Then as you come deeper, you will find that this follicle, let us show the follicle in red color, nucleus here. This follicle is now coming deeper, and it will be covered by granulosa cells. First they are unilayer, then they become multilayered. So this was the primordial follicle, which we have shown, primordial follicle. Now we are showing primary follicle. So how will the primary follicle appear? Let us show this is the primary oocyte. That is the primary oocyte, and primary oocyte covered by first a single layer of cuboidal cells and then multi-layered cuboidal cells, which are called granulosa cells. And these granulosa cells are important because they get the androgens from the theca lutein cells and convert it into estrogen. They also give us inhibin, and later they will also be forming zona pellucida. Now this is about primary follicle. What about secondary follicle? As you look at the secondary follicle you will find that this was the primary oocyte. This primary oocyte gets covered by what is called as the zona pellucida. This is zona pellucida. So if that is the zona pellucida, which is glycoprotein membrane to attract the sperm for fertilization, is given by not only oocyte but also the granulosa cells, which you can show now on the outside. These are the granulosa cells, multi-layered now, cuboidal cells. But outside that you will find we are having some stromal cells which have accumulated here, and they are called the theca cells. So theca cells come from the peripheral stroma, and theca cells, they'll form theca interna and theca externa. Externa will be actually fibrous, but theca cells in the interna, they'll be under LH hormone, and under the LH hormone they will give us the androgens like testosterone. We understand that we don't need testosterone in much level, so minute quantity in female, but then these androgens which are being secreted by the theca cells under LH, those androgens are being given to the granulosa cells, and granulosa cells convert them into estrogen, as we mentioned here. So this was primordial follicle, primary follicle, secondary follicle. Now we are going to tertiary follicle. Tertiary follicle is also called as Graafian follicle. And remember that in the primary follicle, we were having some granulosa cells around, there's some space start developing. So those spaces which start developing are called antral spaces. Antral spaces are seen in the secondary follicle, and they become large in tertiary follicle. So this is tertiary follicle or the Graafian follicle. You will see there is primary oocyte. It is covered by the granulosa cells which will form the corona radiata, and this is the corona radiata. And then you will find that some cells are connecting it to the periphery, and in the periphery you again have granulosa cells, but the space which we are talking about, there will be a space developing here, that is the large antral space. So that is large antral space which you can mark here. This will be large antral space in case of Graafian follicle. tertiary follicle, and the cells which are attaching this oocyte, which is still primary oocyte, are called as cumulus oophorus. So that will be cumulus oophorus, some of the granulosa cells connecting the oocyte to the peripheral cells. They are all granulosa cells only. And then you will find that just before ovulation, the primary oocyte changes into secondary oocyte, and that secondary oocyte, as it undergoes ovulation, this is the secondary oocyte now, the nucleus, the zona pellucida, and covered by some of the granulosa cells which are corona radiata. So this is the ovulated secondary oocyte. Secondary oocyte will be undergoing second meiosis arrested in metaphase 2 until fertilization, and fertilization is very rare to happen. If it happens, you'll have corpus luteum of pregnancy, otherwise corpus luteum will become corpus albicans. So as you are telling that there will be a corpus luteum of pregnancy, it will give us progesterone and it will give us estrogen also, little bit of estrogen, more of progesterone. Progesterone is the hormone of pregnancy, P for P. Now moving on to the fallopian tube. It is understood when the secondary oocyte is ovulated. Say this was the secondary oocyte which was ovulated, and that secondary oocyte will now be moving into ampulla fallopian tube, because that is where it will be fertilized. So ampulla of fallopian tube, that is where the fertilization will happen. You have to tell that the sperms, they are coming, and the sperms, they have to enter from the vagina into cervix, into the uterus, into the fallopian tube, and they have to reach the ampulla of fallopian tube. So as the sperms, they are ejaculated, the sperms, they will be entering the vagina, the cervix, the uterus, fallopian tube and ampulla, and that they will be fertilizing the oocyte, secondary oocyte. They have to undergo what is called as capacitation, and capacitation takes around 6 to 8 hours. It happens in female genital tract, and that capacitation is basically to expose the acrosome area, so that the sperm get ready for penetrating zona pellucida for fertilization. Not only it will change the membrane properties, but it will also change the motility, that is capacitation. Now conceptus has formed, and conceptus formed in the ampulla will move towards the uterus, because finally it has to implant in the uterus. So let us say that there was fertilization in the ampulla, and now it is moving in the fallopian tube, and it has to get implanted in the uterus. That movement is facilitated by the smooth muscles in the uterine tube. So uterine tube will have smooth muscle, inner circular, outer longitudinal, just like gut tube. It has inner circular, outer longitudinal smooth muscles, and they will help in peristalsis. Not only those muscles, smooth muscles, it also has ciliated columnar epithelium. That ciliated columnar epithelium of the fallopian tube help in moving the conceptus towards the uterus for implantation. Sometime if we have immotile cilia syndrome, which is Carter-Jenner syndrome, you will have decreased fertility and the oocyte may not move towards the uterus, resulting in ectopic pregnancy. That means the baby was fertilized in the ampulla but got stuck in the uterine tube and dies. So when you are talking about the immotile cilia syndrome or Carter-Jenner syndrome, why there is decreased fertility? Because cilia are not moving the conceptus. The conceptus, if it doesn't move towards the uterus to be implanted here, it will be stuck here and resulting in what is called as ectopic pregnancy and decreased fertility. So as you look at the epithelium, you see these black arrows. Black arrows are showing ciliated cells, ciliated cells, ciliated cells, and oval basal nucleus, oval basal nucleus, oval basal nucleus. So you will see that the epithelium, if this is the basement membrane, the cells are columnar, oval basal nucleus, and they are ciliated. That cilia is important to move the conceptus towards the uterus. So ciliated columnar epithelium, Along with that, you will have some cells which are bulging nucleus towards the lumen, and they are PEG cells. PEG cells give nutrition. They are for the purpose of nutrition. You can see them also. Bulging nucleus, green arrow, bulging nucleus, green arrow towards the lumen, and these cells, the green arrow, they are the PEG cells, and PEG cells are for the purpose of nutrition. So, as we have mentioned, PEG cells for nutrition, these are the two cells which you find in the fallopian tube. Now, once we have mentioned about them, you can move into the details of the uterus, cervix and vagina epithelium. The uterus is actually having endometrium, where you will have epithelium, and then you are having myometrium. Myometrium is the smooth muscles of the uterus undergoing contraction during the delivery of the baby, mostly under oxytocin, but also autonomic nervous system is working. And uterus will have a perimetrium. Perimetrium is basically peritoneal serosa. So, there is a broad ligament covering the uterus, and that broad ligament which covers the uterus is double fold of peritoneum on the outside. So, that will be perimetrium, peritoneal serosa of the broad ligament. So, the three layers of the uterus. Now, what is the epithelium like? Epithelium is just like uterine tube. It is simple columnar, but without cilia. Very few scattered cilia may be there. So, simple columnar epithelium in the uterus, endometrium, with few cilia. The same thing you can talk about endocervix here. Endocervix will have simple columnar epithelium, but then as you focus upon the ectocervix, now this is ectocervix which is protruding into vagina, it will have same epithelium like vagina. So, what is ectocervix or vagina lined by? They are stratified squamous epithelium, and since they are wet, it will be non-keratinized. So, non-keratinized stratified squamous epithelium. I will repeat. What was the epithelium of the fallopian tube? Fallopian tube was ciliated simple columnar epithelium. What is the epithelium of the uterus? It is again simple columnar epithelium with scattered cilia. What is the epithelium of endocervix? Endocervix is simple columnar epithelium. But if you talk about ectocervix, which is projecting towards the vagina, it will have the same epithelium as the vagina. So, what are both having? Maybe it is ectocervix or vagina, they are having stratified squamous epithelium which is wet and non-keratinized. You see, this ectocervix is shown here and endocervix is shown here. There is a squamocolumnar junction, and that squamocolumnar junction is important because it is always prone to metaplasia, which can change into dysplasia and cancer, CA cervix. So, we have to talk about that, and let us draw this diagram ourselves. So, when you are drawing this diagram, you can tell this is the uterus, this is the cervix, this is the vagina, this is the uterine tube, that is the ovary. Ovary give us secondary oocyte. Secondary oocyte is undergoing ovulation. Then it will be moving into the ampulla of the fallopian tube. In the ampulla of fallopian tube happens fertilization. If you had the sperm coming, the sperms they are coming here, and the sperms they have to move through the vagina. This is the vagina. Then they have to move through the cervix, and from the cervix they have to move into the uterine tube, and then they will be fertilizing the secondary oocyte in the ampulla. That is the path. In that path they have to undergo what is called capacitation. Capacitation is for 6 to 8 hours. They are modifying the membrane, especially the acrosomic membrane, and so that to get ready for fertilization, get ready for penetration of zona pellucida, because that is required for fertilization. That is capacitation in female genital tract. Now, once there is the baby formed, the baby which is formed here is moving towards the uterus, and it is moving towards the uterus because implantation happens here. That movement towards the uterus is facilitated by the cilia and also the smooth muscles of the fallopian tube, and that is basically doing peristalsis. You need the peristalsis to bring the baby to the uterus, otherwise there can be ectopic pregnancy. Ectopic pregnancy can also happen in immotile cilia syndrome if cilia is not helping. Both of them should help push the baby towards the uterus. Now, what is the epithelium of the uterus then? Epithelium of the uterus is simple columnar epithelium, and that simple columnar epithelium of the uterus is same for endocervix also, endocervix. So, maybe it is endocervix or uterus, they have simple columnar epithelium. But then if we are talking about the vagina, it will be stratified. You can write here, this is the vagina now, and vaginal epithelium is stratified squamous epithelium, and this stratified squamous epithelium is non-keratinized because it is a wet surface. Same happens with the ectocervix. This is the ectocervix protruding into the vagina, will also have same epithelium. Now you have to remember, the endocervix has columnar epithelium, and after puberty there will be ectropion. Some of the endocervix epithelium goes project into the vagina, it is called ectropion, under the production of estrogen. So there is a process called as ectropion, cervical ectropion. And why cervical ectropion happens? Because you have more of estrogen. When you have more of estrogen, when you have puberty, so with puberty you have more of estrogen, and there will be cervical ectropion, means simple columnar epithelium of the endocervix is now protruding into the vagina. Vagina has acidic pH, so as it is exposed to acidic pH, it will change into stratified squamous epithelium, and this is called physiological metaplasia. So this is physiological metaplasia, and there is a change of the type of the cells on the cervix. So some of the ectropion happens as the endocervical part goes outside, projecting into vagina, it will change into stratified squamous epithelium. But postmenopausal, it again goes back. Why? Because then there will be less of estrogen, it goes back. That transformation zone is dangerous because that is prone to metaplasia, dysplasia, and cancer. Already there was physiological metaplasia, it can become pathological metaplasia, dysplasia, and cancer. So ectropion is endocervix moving out because you have more of estrogen in puberty, but after reproductive age, when menopause is there, there is withdrawal of estrogen, and that tissue goes back because there is withdrawal of the estrogen. That transformation zone is prone to dysplasia and cancer. That we have to remember. So now vagina is wet, but vagina itself doesn't have any glands. How come it is wet? So vagina has no glands. Vagina has no glands. How come it is wet? Because of some reasons. What are the reasons? Number one, it is the cervical glands which give secretions, and those secretions keep pouring towards vagina. So cervical glands give secretion, and their secretions come to the vagina, and that is keeping the vagina wet. Vagina doesn't have its own gland. All MCQs. Number two, vaginal wall is highly vascular. It will have blood vessels. Those blood vessels will give some transudations. So some fluid will transudate and keep the vaginal wall wet. Plus, at the opening of vagina, you will have the great vestibular gland of Bartholin, and those great vestibular gland of Bartholin, they also keep giving secretion at the opening of the vagina. Now, as we have told, any external opening should be lined by stratified squamous epithelium. The opening of the duct of Bartholin is having same epithelium. Now, what about December 21 question asking identify the arrow marked follicle? We know there are primordial follicle in the social cortex, then there are primary follicles which are two type, single layer of granulosa cell, multi-layer of granulosa cells, so you can mark them. These are primordial follicles, these are primordial follicles in the periphery. Then these two, they are primary follicles lined by single layer and multiple layer of the granulosa cells. So this is primary. What you are showing the marker is secondary follicle, but how do you know that it is secondary follicle? What is the identifying feature? Identifying feature is, you see, antral spaces. Antral spaces have started appearing among the granulosa cells surrounding the oocyte. So secondary follicle is antral follicle. It becomes large and single cavity, antral cavity. If you are talking about the tertiary follicle, this is the tertiary or Graafian follicle, and it is the Graafian follicle which will be undergoing ovulation, shown here. So that will be the large antral space in the tertiary follicle. And secondary follicle will also have zona pellucida around the primary oocyte. Zona pellucida around primary oocyte. So if you are talking about primordial follicle or primary follicle, they are preantral. Preantral are two of them. You'll see that this is having no antral space, these are having no antral space. So these are the primary follicles, those are the primordial follicles. Primordial follicles and primary follicles, they have no antral space, so they are preantral. But arrow mark is on the secondary follicle which will have antral spaces, so it is antral follicle. You'll keep your answer as the antral follicle. Antral follicles are two of them, the secondary follicle which the arrow mark is showing here, and also the tertiary or Graafian follicle which you can show here, this one or this one. So here the arrow mark is on the antral follicle, or you can say it is secondary follicle. This is also antral follicle, it is tertiary follicle. If you say preantral, they are the primordial and primary follicles. Primary follicles are two unilayered, multilayered granulosa cells. So the answer should remain antral. Now look at this question. Fallopian tube is lined by, we already know, fallopian tube is lined by ciliated columnar epithelium with PEG cells for nutrition purpose. And if you are talking about the uterus or endocervix, then they are lined by simple columnar epithelium. They don't have cilia, no cilia. So here we should keep our answer for fallopian tube or uterine tube as ciliated columnar. If it is affected in immotile cilia syndrome, there can be decreased ectopic pregnancy chances and decreased fertility. If you talk about the male, immotile cilia syndrome can happen in male also. The flagellum, which is long cilia, is not working. So even male infertility or decreased fertility in Carter-Jenner syndrome, because that tail of the sperm is not moving. If the sperm is not moving, decreased chances of fertilization. So that can happen in male as well as female when you talk about immotile cilia syndrome or Carter-Jenner syndrome. Anyway, fallopian tube is lined by ciliated columnar. Choice C should remain the answer.